Thank you very much. So the first question we have it from Argentina. It's from Diego, not Diego Maradona. No, Diego Heberman. And Diego from Argentina, he always checks the participants, and if he doesn't see the Brazilians joining, then he joined the meeting. So he's joining the meeting today. Diego, do you want to give the question?
Yes, good afternoon to everyone, and thank you very much for the opportunity. I don't know if it's exactly the topic of this talk, and I apologize if you think it's unfit, but I would like to know if you have radiologists as part of expert committee in the National Organ Procurement Agency in order to improve the organ allocation when supplementary MELD points are requested when you see an HCC within Milan criteria. I mean, that points are given not only for the report of each hospital, or also you have some experts in the OPTN or your organization.
Yeah, so radiologists aren't part of that national committee that that decides on that. We have there's a national review committee, it's called, and that's usually made up of liver transplant surgeons, hepatologists, and in fact, I think there's even some lay people on there, but there's no radiologist on there. But the radiologists were very key in the designing of the protocols and the allocation point system as to prioritization of it, especially the LIRAD system and allocation of points. So UNOS has utilized radiologists in subcommittees for these, though they don't sit on the actual review board.
Thank you very much. In my country, the name of the agency is INCUCAI, and there's also not radiologists, and we had some troubles concerning the heterogeneity of the equipment and the experience and this report system. No, we try to input the LIRADs and still not well accepted. So we're struggling and fighting to get that. Thank you very much.
Thank you very much, Dr. Heberman from Argentina. By the way, we have Alessandra from Brazil here. So Daniela is not here, but Alessandra is here. Second question, Dr. Serlin. Are you ready, sir?
Oh, yes, that was, thank you. That was just a phenomenal lecture. I echo everything that Khaled said, and I also would also like to emphasize that I really appreciated how conceptual you were, and really, you know, took time to, you know, explain to those of us who are not surgeons, you know, how you think as a surgeon, and you put it into a conceptual framework that made it very easy to follow. So I hope you don't mind, but I will certainly be teaching a lot of what you taught me to others. But I won't give you any credit for it. I'll just say I came up with it all on my own.
No problem.
Okay, no problem. So I'll just say that, you know, I'm just so smart that I just thought of this on my own. But anyway, really, really nice lecture. One question I have for you is the following. You were very modest about this, and you went through that. You showed a slide for maybe, I don't know, a second, but you showed a slide that showed that Pittsburgh, I believe, is doing something like 70 plus living donor transplants for liver a year. And it looked to me like maybe second place in the United States was maybe about a third as much as Pittsburgh. It seemed like maybe some centers are doing 25. So first of all, is that about right, that you guys are like 3 times, your volume is about 3 times higher than the next highest center in the United States? Is that correct?
Yeah, that's about right.
So I guess, so to what, and this is obviously maybe a little bit of speculation on your part, but to what do you attribute, you know, maybe phrasing it in a positive way, your success, and how can we bring some of your success to other centers?
So I think success is sort of multifactorial, but I think what it really requires is a commitment of the entire center to be behind this. So everyone has to speak the same language in terms of commitment to this procedure, and that's what we worked very hard. And it took some time because, you know, the only way that people buy into something is really if you can demonstrate that you're able to do it with high outcomes and good success rates. So we first had to really labor at making sure that we were getting good outcomes, and then we had buy-in from everyone. By buy-in, I mean, you know, the hepatologists who are referring these patients, the nurses who are looking after them, all of the people that someone may come into contact with in their journey of liver disease. If any one of them along the line says, no, this is a dangerous procedure, this is experimental, this is this, right away the patient will pick up on it, and that's it. They're difficult to convince them otherwise. But if everyone is speaking the same language of, look, this is an option, it's a good option in certain situations, these are the advantages of it, there are some disadvantages, this is what can be gained from it, and think of it really as a first-line treatment for everyone rather than something you want to do as a last resort, then patients are very willing. In fact, you know, we find that that donors are much more willing in terms of risk than we ever would be with them. So I think that's the first key part of it, is that everyone's got to buy into it and believe in it, and you can only do that by having a good product.
Yeah. How many surgeons at Pittsburgh perform these operations? Is it only you, or are there other surgeons who also perform these?
So you need multiple surgeons during the procedure, because remember, there's two procedures going on simultaneously. There's the donor operation and the recipient operation, and what we've tried to do is standardize it as much as possible so that we're getting maximal experience and everyone is comfortable with it. And you can do that because they're essentially elective in the sense that you're not doing these in the middle of the night. You can time them to be when you want. So we do it with the same, you know, 2 to 3 surgeons every time.
Okay. And I'm curious what the costs are of this operation compared to a deceased donor. I mean, on the one hand, it's 2 operations, as you just pointed out, but on the other hand, the patients aren't critically ill and they may not need to be in the ICU for as long, and they seem to have lower frequency of complications and reoperation. So could you comment a little bit on that?
Yeah, that's a great question, and we've actually done quite a detailed financial analysis on this. And you're right, it is cheaper to do a live donor transplant because, and it's 2 operations, but you know, people forget that the deceased donor transplant is also 2 operations, because the procurement of the deceased donor organ comes with a significant cost. So when I take a liver, for example, for someone from outside, there's a charge associated with that, and that charge actually is more than the charge of doing a donor surgery here in my hospital. So in fact, the cost of doing a deceased donor transplant are about 30% higher, and for the hospital, the margin on it is about 30% better.
Fascinating. In terms of HCC, how far beyond Milan criteria are you willing to to go with something like this?
So we're willing to go quite well beyond, as long as we have some demonstration of biology of tumor. That it's because we've seen some very large tumors that have very good biology, meaning that they have low AFPs, they have the tumor's been stable for some time, they've been with it for many months or whatever, and we've been willing to transplant those patients, even those that have 10, 12 centimeter tumors, sometimes even bigger tumors, that we've done. What we've tried to do is as I said, biology of the tumor more than the actual just size of it. So often in these patients that are well beyond criteria, what we try to do is sample some of the do a percutaneous biopsy of the tumor ahead of time, and then we have an ingrown lab test that we've developed that really looks at various genetic markers on the tumor cells, and based on that we can try to predict the risk of recurrence on that, and if they have a low risk of recurrence, then we'll transplant them.
Wow. could imaging be of help to you in guiding the biopsy to the most, aggressive part of the tumor?
Yeah, the most aggressive and the largest of those is what we generally try to biopsy.
I see.
Yeah.
And then
those biopsies are all done by our radiologists. These are all percutaneous biopsies.
Yeah,
that we're doing.
interesting. You mentioned that you rely a lot on intraoperative cholangiograms. In fact, it sounds like you do them with every operation.
Yeah.
Because as a radiologist, I'm always sort of curious about this sort of thing. So I'm wondering, is there anything that we could do, if we provided sufficiently good images to you of the biliary system, would you not need to do that, or would you still need to do that because you still need to know exactly where you're going to be clamping the bile ducts and exactly where your surgical margin is going to be?
Yeah, so yes, I would still do it, because what I do is I put a clamp exactly where I'm going to cut the bile duct, and then I shoot a cholangiogram at that point, and that tells me exactly where my line is going to be and that how big my stump is going to be. And that, regardless of how good your imaging is, you won't have that intraoperative to be able to make that decision. So I think intraoperative, if the MRCP could be better in terms of imaging, it would be helpful, because of at least of all the various things that I look at, I still find the bile ducts are the ones where I have not as much clarity as the other things.
Okay. Well, I have some ideas along those lines, and maybe we can interface, offline about that.
Yeah, that would certainly be helpful. The other thing that would be helpful is a one imaging to do everything. So I've talked to our radiology colleagues about whether we could get the same degree with just MRI so that we could do MRI and that, so that patients don't have to have a CT and then an MRI to get everything. If we could get all the volumes, etc. And certainly I think some centers do that. They just do MR and that gets everything, including the vascular imaging and the
challenge is the arterial anatomy.
Right.
These could also be discussions offline, but with MR, we can give you the bile ducts better than with CT. Obviously, we can give you the hepatic veins. We can give you the portal veins. The challenge with MRI is the hepatic arterial anatomy. That there's going to be some small arteries that we're just not going to see. And like one of the cases you showed, where I think you showed a case where segment 4 was being fed, I think, by a branch off the right hepatic artery. That was a really tiny little branch, and I don't know that we could give that to you right now with current technology and MRI all the time.
Right.
But anyway, these are also ideas. And then I just have one last question, but then I'm happy to turn the floor over to others. I don't want you to feel like I'm overwhelming you here. I'm sorry about that.
No problem.
Yesterday, Amir mentioned proton density fat fraction of the donor liver, but you didn't talk about that at all. Is that not relevant to you, or is that useful to you, or how do you use that information?
Yeah, we use that very much, actually. So in assessment of our donors, the most common reason why a donor is turned down anatomically is because they have a fatty liver. So we rely on the proton density, and it's pretty accurate. So we know that if it's mild steatosis on the MR below a certain percentage, that they're going to have less than 10% actual steatosis when we biopsy them, which is acceptable. If it's anything more than that, then we generally exclude them from donation.
Got it.
So that is very helpful. Yes.
And so that's kind of the magical threshold for you, is 10% steatosis histologically.
That's right. Yeah.
Great. All right. Well, thank you so much. Thank you for your patience with all my questions. I really enjoyed your lecture. And I must say, I really enjoyed this last slide and how you talked us through the human stories behind it, which just was very powerful. So again, thank you for everything.
My pleasure.
Thank you.
So King Khaled, it's back to you, and maybe other people have additional questions. I don't know.
Thank you very much, Claude. We appreciate your questions and a nice discussion that is teaching everyone. And thank you, Dr. Humar, for being patient with my friend, Dr. Sorlin.
My pleasure.
So last comment we have it from India, from Sandeep, Dr. Sandeep Vora. Sandeep,
Yeah.
yes, sir. Can you would you want to first of all, thank you very much for joining us from India. Would you like to give the question or the comment?
Uh, Good evening. Thanks, sir, for a very comprehensive lecture on the role of imaging from a transplant perspective.
My pleasure.
Hello, am I audible?
Yeah.
Okay. I'm working in India. I'm working in Delhi. I'm basically attached with a liver transplant team, and I would just like to make a comment for the audience on the safety of living donor liver transplantation. That we, in our last 15 years of experience, never have had any major issue with the donors. And with the volumes of around 200 to 250 liver transplants every year. And so I would just want to bring to the attention of all the audience that LDLT, especially in settings where diseased donor livers are not available, is a very good option as a life-saving procedure in all patients with end-stage liver disease. Thank you.
Thank you,
Thank you.
Dr. Humar.
Yeah, no, I agree. It's certainly a life-saving procedure for many, though I would caution that you should never be cavalier about this, because it is a major operation for the donor. And to say that, you know, that we can do this with 0% risk to the donor, I think is not not correct, because there have been many deaths reported in India with the donor operation, and fortunately none at that center, but obviously many centers have had deaths in India, and I think the important thing is to make sure that this data is tracked and is transparent. So in the United States, you know, I can tell you with 100% confidence that there have been 6 early deaths after living donation, and but that data is not forthcoming in many places around the world, unfortunately. So, for example, I'm pretty sure Sandeep can tell me right now how many deaths there have been in India after.
We have had 2 donor deaths in 15 years, and both from subarachnoid hemorrhage, and we could not figure out why did that happen.
So that's just in your center I'm talking about, Sandeep, but
Yes.
But you know, there are, I don't know how many.
There is a learning curve. I agree with you, and it is a very tricky and a very difficult surgery. I always say hats off to the liver surgeons for the kind of surgeries they do. I really hats off to them.
That's great. Okay, so with that, I would actually like to thank you, Dr. Humar. This was a really great lecture. We really appreciate that, and
My pleasure.
thank you very much. We now have some good understanding of what the surgeons do on the surgical side, and thank you very much for joining from all over the world. And with that, would end our session today, and look forward to seeing you again tomorrow with Dr. Antang from Canada.